Hello, good evening, everyone, and welcome to another one of our Facebook Live sessions. My name is Bev, and I'm the host for tonight's sessions. And tonight's topic is all about palliative medicine and ensuring a possible quality of life with a life-limiting illness through palliative care. And it's specially brought to you by 365 Cancer Prevention Society and our esteemed medical partner, Icon Cancer Center. So please like and share and comment on both of our social media pages so that it can reach out to more people. Now, 365 Cancer Prevention Society was actually founded back in 2003 as a social service agency with IPC status, and we are a full-fledged member of the NCSS. The society's mission is to serve the community through our holistic cancer prevention measures. This is accomplished through our health and nutrition education, promotion of healthy lifestyle, and our lymphatic detox exercises. We also provide practical and emotional support through our care for our members and their family members in their battle against cancer through our residential and hospital visitations, counseling, and wellness services. So please remember that no one is alone in this fight against cancer. We hope that you can join our community in this fight against cancer today. For more information, do visit our official website and follow us on our social media platform. So before we start our talk, I'd just like to read out a disclaimer. So please kindly note that all information shared at this event by the speaker and 365 CPS are for general information only, and they are subjected to changes. Do consult your doctor for personalized and detailed medical advice. Thank you. And to mark Colorectal Cancer Awareness Month in March this year, Icon Cancer Center and 365 CPS has decided to come together jointly to organize My First Colonoscopy. This campaign is worked together with partners such as the Society of Colorectal Surgeons and StarMed Specialty Center. This campaign actually aims to support individuals aged 45 to 70 from low-income family and those who are of a higher risk due to family history and symptoms. So this is to do a fast-track sponsored colonoscopy by experienced surgeons from the Society of Colorectal Surgeons and complete with a pre and post GP medical consultation at StarMed Specialist Center. Meaning to say, the beneficiaries of this sponsored colonoscopy don't have to wait for months for an appointment to see a doctor and to do the colonoscopy. Everything is done at StarMed Specialty Center by qualified and experienced doctor. So from seeing a doctor to the scope, it all takes in a matter of few weeks only. And each and every one of you, you are the one making a difference and making all of this possible. So you can do your part by donating towards this campaign. Right now on the screen are our QR code. So you just need to scan the QR code and check them out online through portals such as giving.sg and Give Asia for more info. And if you wish to find out more about Icon Cancer Center, the Society of Colorectal Surgeons, or StarMed, do feel free to check out their websites and social media pages. Now, before we begin tonight's talk, I would like to take this opportunity to introduce the speaker for tonight. Dr. Francis Chin is a senior consultant in the radiation oncology and palliative medicine. He is also a clinical oncologist and was with the National Cancer Center for over 20 years. He is the immediate past president of the Southeast Asia Radiation Oncology Group. And he is an active principal investigator in trials and deputy chair of Sing Health Institutional Research Boards in Oncology and Hematology. So without further ado, we are very privileged to welcome Dr. Francis Chin tonight. Hi, Dr. Francis Chin. You're on mute. Maybe you can unmute, then we can,
Hi,
I can hand it over to you.
Yes, thank you very much for that kind introduction.
And thank you for joining us tonight and sharing information with everyone. So I'll be taking my break right now, and over to you, Dr. Francis Chin.
Thank you. I'd like to wish everyone a good evening. Thank you for coming to share to this talk organized by 365 CPS. The title of my talk is Understanding Palliative Medicine, which is also known as palliative care and hospice care. These terms are used interchangeably in this talk and in the Singapore context. And I will try to talk. Why would anyone, what is palliative care? Why do we need palliative care? When do the patients need to be assessed for palliative care? Where to get it? And then how does the patients actually assess it? And who are involved in giving out palliative care? So palliative care is usually when we refer to patients who are at the end of their life, usually after a long battle and journey with cancer. Not everyone is able to get cured. And especially if one's loved one is diagnosed with a life-threatening disease, this is very important to manage the long-term care and support, especially as the disease progresses. Certain complex conditions may arise, and these need to be taken care of. And palliative care aims to relieve the suffering and improve the quality of life for these patients and also the family members by caring for the whole person physically, emotionally, psychologically, and spiritually. And we seek to support the patient throughout this treatment process, involving the family as well. The holistic care is very important because in Singapore, the family forms the unit where they are often involved with the caregivers, and lots of people are involved in this palliative care. It is a multidisciplinary team which includes the doctors, the nurses, social workers, therapists, counselors, as well as trained volunteers. And we put the patient in the center of what we do because it is a complicated matter. After a long battle and journey, each individual may approach dying in a different way. It always starts with conversations, and it includes physical, emotional, and psychological assessments because it is tailored to, there's no one way to actually treat a person. And I often say that the motto that we have is that we live well so that we can live well, because dying, we can also die in a good way with dignity. And the aim of palliative care for a lot of the patients is that we want to add life to the days that we have. It is not to unnecessarily prolong the life of someone who has reached the end of treatment, but so improvement of the quality of life is the most important. And there are certain symptoms that are more common at the end of life. It may include pain. Some patients will also suffer from poor nutrition and cachexia, which is actually a great loss of weight and loss of appetite. There may be organ failure, as some of the cancers may spread to some of the critical organs. And it is both distressing for the patient as well as the family members. Some of them are often breathless and dysphagic, which is difficulty in swallowing. So the whole multitude of the team is involved in all this multitude of symptom control and pain. And we try to actually, many people are involved, and some of these things like pain, cancer-related symptoms, we aim to dispel the stigma of analgesia. A lot of these patients often require morphine or some type of morphine. There are many drugs that we can use. We use a stepwise approach, always on the clock. We try to use oral medicines as much as possible, and we titrate the pain according to the patient's needs, starting with simple medicines for mild pain, increasing it from mild and moderate pain to stronger medicines. And then in some very severe pain, we may use opioid or opioid-like medicines. There's a whole constellation of medicines, including syrup, morphine, codeine, oxynorm, or even patches if the patient is unable to swallow. Often, as I alluded, patients have poor nutrition and they may waste away, and often this is distressing for the family, especially in our Asian context, because for us, giving someone food is actually a way of showing love. And for many of these patients, we will often suggest nutritional control, support. Some of these patients may get total parenteral nutrition. They may even get a drip if they are poorly hydrated. And we try to direct the care at home. This is the where. There are many resources where the palliative care can be directed. It may start early in the patient's journey, where they will get some form of care at home. There are many multiple resources in Singapore where there are even nurses from the Hospice Foundation to visit them at home, to administer wound care, to give simple medicines, and to actually assess the symptoms. These nurses are well trained and will visit first with a telephone call, and then in the serious cases, will go down to the patient's home to see them out. If there are issues to be addressed, they will escalate it to the doctor and then either make a decision whether to care at home or to get the patients into one of the community hospitals or the hospices. It includes home delivery of medication. Often these medications may be top up of painkillers, and also access to the numerous support services available in Singapore. There is a Hospice Council Association, which is an umbrella association for all the palliative care services available in Singapore. So what does it involve? I've alluded that it is both physical, emotional, psychosocial, and spiritual care. Regardless of what we believe in, I believe in humans, after a long journey, we reflect and we have a life story that we want to tell. Again, the question being asked, when do the palliative care physician is being involved? Is it when someone has advanced disease and stage 4 and is really dying? We often say that we would like to be involved early on, once the patient has incurable disease at stage 4, because it all begins with a conversation. There is counseling to give the emotional support, and there is the need for grief. Even before bereavement, there is a grief. Often some patients would have been diagnosed with stage 4 from the start, but for many of the patients, they may have had been battling with cancer for a long time, and it may be many years later they get a recurrence. Often there is a response, and each patient's response to it is different. The counselor or the doctor, or even speaking to a nurse, may help the patient come to terms and accept her condition. And the palliative care physician has opportunity to intervene and refer the patient to the necessary support services. And some of this, and like I said, to manage the symptoms if there are symptoms, manage the nutrition, manage the pain, manage obstruction, and any other, such that the quality of life in the last dying days of these patients are meaningful to them, They have the conversations that require to talk to the family. And we can cite it at an appropriate place. It may be home care, daycare. A lot of societies, including 365, as well as the various hospices, SCC Hospice, Dover Park Hospice, they have daycare for their patients. It offers some respite care for the caregivers who have been taking care of the patients, and the patients can come to the various daycare centers to offer respite care for their caregivers, and also to interact and engage in things like even art therapy, music therapy, and some of them find solace in being with and talking to other people in the same situation. There are also inpatient services, especially when there is acute services that need to be managed, like obstruction, loss of weight, or impending infection from organ failure, or even cancer pain that needs to be managed. And especially there is also a group of patients, they may opt to actually, the majority of which we hope, depending on their wishes, whether they wish to die at home among their loved ones, or some would feel that they want to be managed in the hospital, in a hospice environment. Usually the admission is when you have less than a month, and it is there are various hospices that I will talk to about later. And the who benefits from this palliative care? In fact, all patients with a life-limiting or life-threatening disease benefits from palliative care. And so it includes people with metastatic or advanced cancer. I am an oncologist and I deal with this particular subset of patients. But anyone with a chronic disease in Singapore, including end-stage renal failure, liver failure, lung, heart, or advanced dementia, may also benefit from seeking services of a palliative care consultant and assessment of all the symptoms and needs appropriate to them. So again, where can one get palliative care? We often aim to site it at the patient's home, but there are also, and this is where they are surrounded by their loved ones, but there are also nursing homes and hospices and inpatient and general community hospitals sited all over Singapore, where one can get access to this care. And I've alluded to this before. In dealing with the emotional and complex psychosocial and as well as cultural beliefs, all palliative care starts with conversations. Often the doctor is an intermediary with a counselor to work out the relationships. There may be a lot of guilt involved, especially if nowadays we all lead very busy lives, and there may be children who were not as actively involved in the care of a dying family member. And often these relationships need to be resolved, and as well as conversations. Often we would want them to start early, because we would want to know the wishes of the dying member with regards to what they would like to tell their family members, the memories they would like to live on, their own life story. We facilitate this with life story tales and questions. And again, there are many care preferences, including people who may want to to organize their own funerals, organize the end of life events, and also to leave behind, it is regards to their personal beliefs, what they believe in, and what they want to be with at the end of their lives. And finally, cancer is quite an expensive condition. Often, financially, it could be ruinous, and there are many issues that need to be dealt with, many legal, ethical, and as well as whether we pursue unnecessary or expensive life extending treatment. So all these need to be worked out, and often some of these services, including the health home care nurses, they are often provided for free, because they are run by charitable organizations, and which are often supported by a small stipend from the government, but mainly also by donations. So when do we involve again? I mentioned ideally it should be early in the diagnosis of a serious illness. Speak with your doctor, and so that the trust is built up. We would rather see someone early in the stage 4 disease, because we know when it's stage 4, the disease is incurable. Often we would need to begin the conversations that I've alluded to. We need to know the patient's preferences so that we can work in conjunction with the current treatment. These patients at stage 4, they may still be on systemic chemotherapy early on, especially if the diagnosis is early. And sometimes there is a first line, there's often a second line, and sometimes in conjunction of discussion with your doctors, some patients may opt to stop further treatment. I am also a radiation oncologist, where sometimes we offer not just using pharmacological methods, but we also use radiation to treat sites of cancer pain, and especially for the bones, or if it has spread to the brain, we treat with radiation to prevent a stroke and to prevent bleeding. The role of radiation is in 3 specific areas. It is good for cancer pain. Even though we radiate the tumor, it may not be curative, but it stuns the tumor and reduces the pain required. So less medication is required to control any pain, and patients can lead a productive and healthy life at the end of their life. And we also use it to control uncontrolled bleeding. For example, if someone has stomach cancer and there's bleeding from the stomach, often these are unsuitable for an operation. So we use radiation, which can actually be used to stop the bleeding in some cases, alleviating the pain, and alleviate this acute episode. We can also use it in some cases when there's obstruction. So radiating a lesion can actually relieve the obstruction. With some of these patients cannot eat because there's metastasis in the gut, in the stomach, and this may be the cause of their cachexia and lead on to infection, bleeding, organ failure, and eventual terminal death. Again, these are all general advice. Your specific, seek your doctor's advice if you're in this advanced stage of disease, and if necessary, a referral to the palliative care physician or the counselor or guidance counselors. So just a list of the palliative hospitals hospices, community hospitals all over Singapore. That it was, in the old days there were only a few, but nowadays there are many hospices or community hospitals all over Singapore, because the government realizes that this is a priority area and has built numerous hospitals. Some of them are public, some of them are actually supported by fundraising. One of many of them are next to hospitals. For example, the CC Hospice is next to Mount Alvernia Hospital. Dover Park Hospital is next to Tan Tock Seng Hospital as well as Mount E Novena. Renshi is within the Tan Tock Seng Hospice in the center of Singapore. The Outram Community Hospital is in the Singapore General Hospital campus, a newly built community hospital. Sengkang Community Hospital is near Punggol, where huge population centers are. St. Andrews is, if I'm not mistaken, is in the east near Tampines. St. Luke's in the west. Yishun Community Hospital as well as St. Joseph's Home near Jurong. And the how does this process work? Often the doctor will refer to this collective agency called the Agency of Integrated Care. Often nowadays, if you visit any community center, there will be advertisements or brochures. It is an agency. You require a referral from the doctor, but it will be assessed. There are financial schemes that will help these patients, and then they are referred on to right site and matched with a nurse and to the appropriate services. Referrals to the hospices are also through the AIC website as well as the Home Nursing Foundation. Again, I would like to repeat that it takes a village to manage a patient, and it's a multidisciplinary care that is required. You have doctors, nurses, the medical social workers, counselors, and the various therapists. Palliative medicine physician will manage the symptoms like pain, breathlessness, nausea, vomiting, obstruction, wound care, and bleeding. The counselors will offer emotional, spiritual, and grief support as well as any other counseling. There is actually even rehab, and the physiotherapy and occupational therapists are also involved. And some patients will find solace in music and art therapy, as well as being with other people when they are not immediately sick. Someone who is stage 4 may go on and on, may have a potential lifespan of even up 6 months to a year or even more, depending on the type of cancer and how advanced the disease is. In general, you can be a stage 4 if you have bone disease, but someone with, for example, breast cancer with only bone disease may go on and on with stage 4 disease being managed quite well. It is still incurable, but there are patients who have gone on for years. I personally have seen a patient, but of course, speak to your doctor. There is many breast cancer, but there was a stage 4 breast cancer with bone-only disease going to almost 9.5 years before it spread to the visceral organs and to the liver, and then when she finally passed on. So she had many years of good years being well controlled on this. So what is end-of-life planning? In fact, this is a very important part of the conversation that you have with the physician. In Singapore, we have what we call the Advanced Medical Directive. to know your wishes, and it relates a lot on the patient's own beliefs and how aggressively they would want to pursue the treatment. Often we will ask the patient so that the decision is not put onto their relatives, or at least when they reach a stage when they are not able to make the medical decisions, their relatives would know what is their own preference. Would they want to be intubated? Would they want to have mechanical ventilation to prolong their life? What does it mean to continue feeding through total parental nutrition, or is fluids enough? Often at the last days, we may not feed the patient, but often you just keep fluids. You have to make sure that the patients are pain-free. That the patients are pain-free, and again, it is often very distressing for family members if they feel that the patient is struggling and having death rattles. There are medications that we can give. It is not that we are not talking about euthanasia, but we are actually, which is illegal in Singapore, but we are giving relief medicines like morphine, such that the patient is not breathless, and then they go off in a way that is dignified, without struggling from pain and from death rattles. Again, back to the legal stuff. Often in these advanced medical directives, there is a portion to give a lasting power of attorney to a family member, usually a decision maker, in case of incapacitation, and it can be divided into a general lasting power of attorney, which is just the ability to make the decisions, or it can be specific subsides dividing into both financial, medical decisions, as well as childcare for patients who may or may not still have young children. And for us medical doctors, it may be the spouse, but may not necessarily be the spouse. But it may also, in certain complicated family relationships, there might be other partners. They may be divorcees, maybe have children, young children from different marriages. All these need to be addressed, such that the patient's wish and dying wish is known, and there is no distress to the family. So I'm almost at my end, where I talk that palliative care also involves counselors, and we offer pastoral care to a lot of these families. I would like to say that if you can see, among the hospice care associations, they often start out very religious based. SCC is Christian and Catholic. We have Rensi, which is Buddhist. Dover Park, which is agnostic. But all of these hospices do not only take in patients within their religion, and it's open to all, regardless of religion. But often, some patients may find or want to speak to a priest, a counselor, or an abbot who will give them the last rites, and they would be regularly visiting these hospices. And the care of the family is as important, because when someone dies, it is always the family that is left behind. for bereavement, and we have to make sure that everyone is well and okay, and it is quite important. Yeah. And with this, I would like to end my presentation and be happy to take questions. Beth?
Hey, hi, Dr. Francis. So, thank you, Dr. Chin, for your comprehensive and your informative content. Right. So, speaking about end of life, is always very taboo and very hard. It's a very difficult topic to talk about. But I do hope that everyone here has picked up some useful tips earlier on. So, right now, like what Dr. Chin mentioned, we will now take questions from the floor. So, if you do have some, you can post it in the comment box right at Facebook, and then we'll pick it up and then we'll answer them. Right, so let's screen the floor for some questions. All right, so Dr. Chin, I have one question coming in.
Yes.
All right, so
Yes.
it's about this chemotherapy. So is it suitable for this palliative care?
Okay. So I would like to mention that there are many people in many stages. Like say, when someone has stage 4, is often considered incurable disease, but sometimes there may be still early in stage 4, and then there are some medications or some lines of chemotherapy not given yet to that may be useful to prolong life and alleviate symptoms. But in general, when we talk about, and we would like to see the patients early, even when they were still receiving chemotherapy. But in general, our understanding of when someone is already receiving palliative care, it will be a point where someone has decided mutually between themselves and their physician to end further systemic therapy and just manage the care based on best supportive or symptomatic care, managing the symptoms like infection, obstruction, bleeding, cachexia, and the like. Usually, these patients would have exhausted all lines of chemotherapy, or they would know that the chemotherapy maybe the response rate is not ideal compared with the attendant symptom or side effect that may possibly come with them. Some people may decide to end treatment after discussion with their doctors. This is when we start to see them.
Thank you, Dr. Chin. Right, so we have one question from our Facebook participant. All right, so it's coming from Papa Rich Wee. It's asking about the difference between palliative care for a young child versus a senior adult.
Yes, I've not talked about this, but I also personally subside in pediatrics. So whenever a child dies, it's always heart-rending, and often painful. It's a different set of problems. There are specific charities like Children Cancer Foundation, Viva Pediatric Cancer Foundation, who are also involved in palliative care. The difference is, I would say, is that it's often a tragedy to lose a child, and depending on the age of the child, some of them, and the most common cause of a child dying either could be solid organ cancers or even leukemia, and often these are relapse. A lot of these patients, for example, for leukemia, they would actually would have some form of response, and they may have had treatment when they were very young kids, and then many years later, when they are older, they get a relapse. It also relates to how much the child understands and the age group of the child, how much they understand that they are going to die and leave the family. Often we use counselors with picture books, talk to them about what they understand about their disease, make sure that we address their fear. And it is especially what I said the last slide, when a child dies, is the care of the family. And also the bereavement process is often longer. In some ways, without minimizing it, when someone has lived a full life, older adult, elderly adult, we often the adults often are very, and I have patients, some of my patients who decide, no, I don't want further treatment, and I'm going on my own terms. So these are the people who have accepted that they've lived a long and fruitful life. They have a life story that they've communicated to the family, and we are all ready to go. We often say, regardless of whether you got cancer or not, we are all born to die someday. It's just how we die. We often say we pray for a good death and to die beautifully, without anything being left behind. Because we come naked to this world, we will live naked. Whether we are billionaire or pauper, once we have made peace with ourselves, with our family, with our maker, often we should be ready to go. And there's also in between young adults, and we see more and more younger adults. They often are with still young families, and then that becomes a problem, because you have a responsibility, and you feel that that's what I allude to, in terms of we have, and without here, I have a picture of a child who went to see the dad for the last time, and the dad suddenly had a heart failure and died. And there was a picture of her by the dad's bedside in the hospital, and it's so rendering. And how do you talk to a primary 3 kid that the father has gone or is going? So these are the things that we deal with every day, on a daily basis, being in this field. But even for so long, there are instances that, some days it's just quite tough. Yeah.
Thank you, Dr. Chin, for that insightful answer. And thank you, Papa Rich Wee, for that question. So we have a next question coming in from Lynn. All right. So it's a long question. I'm just going to try to break it down. All right. So Lynn is asking, there is someone at home who is already at end stage liver cancer and is now in palliative care at home. So
Yes.
what else can they do to make her more comfortable? All right, this is the first part of the question. And she also has fever every day and is experiencing bloatedness and have a lack of appetite.
Okay, this is exactly as we said. She would probably be managed best at home, under the supervision of palliative care physician or even a home nursing. When liver cancer, to be honest, is not a very pleasant way to go. And there's a whole constellation of symptoms, including organ failure. Because the liver is an important organ that is required for detoxification of all the toxins in our body. So people get Huang Dang Bing, they got jaundice, the bilirubin rises, they get fever because of the infection, cholangitis, repeated infection. So they are uncomfortable, they are in a stupor, and they have no appetite to eat. And so it's the whole constellation of symptoms. If there's pain, we can give effective pain medicine. It may be the form of opioids, oxynorm by mouth, morphine syrup through breakthrough, or even fentanyl patches. Fevers, we tend to manage symptomatically. There are some patients who, when they have an acute fever, they do come in, and then we try to give them antibiotics. I often say to my patients, all of us are destined to die, and we know that there are 3 ways to die. Usually, the cause of cancer. First is the cancer creates organ failure in whatever organ, and then it fails, and we go. The second is related also to organ failure. It has infection, and then the infection overwhelms the patient. They have fever and they go. The other part is also sometimes the tumor erodes into a major vessel or organ, and then someone bleeds to death. and that is a quick way of going. We wouldn't know specifically how a patient would go, depending, because it will depend on the disease stage and where the disease is, even in the liver cancers. But without knowing more condition of the patient, often the prognosis is poor. They are often in months or weeks, depending on how much disease there is to the liver as well as spread to elsewhere. But in general, we offer them symptomatic treatment, and in the various ways that I've said, making sure that they're comfortable and the patient is able to enjoy his last days, his or her last days with the family, and not in fever or in pain or tired or not able to eat. Yeah.
Thank you, Dr. Chin, and thank you, Lynn, for your question. All right. So the next question is coming in. All right, Dr. Chin. So speaking about treatments for advanced cancer, right? So how can radiation therapy actually help people with this advanced cancer?
Okay, so I've alluded a bit in my talk that radiation is very commonly used in patients with advanced or metastatic cancer. It's often said that up to 80% of all patients in their cancer journey would require one form of radiation, especially if they have reached stage 4. So, like I said before, it is used for pain control. If there are spinal mats and back pain, or pain in an organ, radiation is given as an outpatient, daily treatments, one time, 5 times, 10 times, or even 12 times. If let's say someone has brain mats, you can actually radiate it such that they do not bleed, and the last few days of the patient is not that they are in a stroke out condition. And we can also use radiation to treat obstruction and bleeding. I gave the example of stomach cancer, but you may also apply with liver cancer, where there are big nodules obstructing the nodes obstructing the gut, unable to eat. Some of radiation, consult your doctor. It may be helpful in shrinking these nodes, and then to avoid bleeding and avoid obstruction. And in some ways, it is symptom control because these patients are incurable, but it is very effective because it doesn't involve a surgery. These patients are in no state to undergo any surgery, and it is often an outpatient and fairly well tolerated.
All right. Thank you, Dr. Chin. So we still have some time, so please keep the questions coming in on our Facebook, right? We'll try our best to answer all of them, right? Okay, this question may be a little bit difficult to talk about, right? So does using palliative care actually means that I'm dying?
Okay. Usually the patients are referred to us when they are in stage 4. And often the criticism is that the patients are referred too late. So our preference is for patients to be referred early once they have reached stage 4. Because the advantage of this is that there's a conversation, the whole constellation of getting access to the services that are required. You are not immediately dying because, as I alluded, there are many people who are stage 4 with low volume disease, which go on and on for years and years. You know, if let's say no one in a way will die from bone disease. You know, you may have breast cancer, but if let's say it's just in the bones, especially if it's hormone responsive, these people have years before they become terminal. So palliative medicine has often been associated with dying. There's a subside of that. It's true that the hospices will only take patients who have an expected lifespan of less than 3 months. But there's a whole constellation and spectrum of palliative medicine where we need to talk to the patient to assess them in terms of the cancer pain. And there are people who have these conversations, the advanced medical directive. You want to be able to talk to your doctor while you are still lucid. These patients are not immediately dying. They have a good expected lifespan, but there's a conversation. As and when they decide to stop more further treatment, if they are too sick for further chemotherapy, then there would already be a rapport built up between you and the palliative care doctor to be able to right size your own needs, where you will be treated, what the further options. Best supportive care really means supportive care, titrating your pain, making sure that you do not lose too much weight, the referrals to the counselors, making sure that the legal stuff is done, advice of end of care. Most of us would not have big wills to give, but the wills may not necessarily be money, but also be entrusting whose care or what to do. And everyone but everyone also would have a HDB flat, so they may not know that, I need to refresh my CPF nomination. All these are necessary, and you should try to do them or reminded to do them early on, especially if you know that everyone has an end date. It may be not immediately, it may be 6 months down the road, 8 months down the road, or maybe in years down the road if you have low volume disease stage 4.
All right, thank you, Dr. Chin. Okay, we have one question coming from our participant. All right, from Frostbite Cool, is asking about any ways to make them happy, which is quite subjective. By them, I'm thinking the one under palliative care.
So
right?
yes, so it is before in my career. Often is the discussion of the patient, and there's the slide that I talked about where we need to know. Sometimes we have the dynamics. There might be family members who want to continue treatment. There might be the patient who have said that, no, I just want to be told the truth and know what it is I want to do. I will relate a story, of a gentleman who, when told that he was going to die and dying, and we have many charities doing this. He wanted to go to have one last fling at the casino. So we arranged the ambulance from I think it was the World Park Hospice, with oxygen, and we called up RWS. They made a special accommodation with wheelchair, and then wow, he was happy. One last fling at the tables. But that's a unique special case. We also have many patients who there was a patient who requested to visit Labrador Park. So there was pictures or videos of us. We brought them there with their family because he wanted to see the sea for the last time, and the park. And he died soon after. So each person will have their own unique, the discussion. They may not want to go for the third, fourth line of chemotherapy, but they may actually say, I want to visit my old school in Penang or whatever, eat one last char kway teow in Gurney Street. These are, if we do not ask, we will not know. So there is, and often it's very simple things like this that make people happy. It's their life story they want to tell, how they go back to, we always go back to our old childhood memories. No matter how long our life we have, we always have that special memory that we want to relive. And often, if you have this amount of time that you will spend, and I would say, as a reflection, when you think about it, it's a philosophical thought. Often it's a blessing to know when you're going to die. All of us are going to die at some point. If you have stage 4 cancer, if someone gives you a diagnosis, you have another 3 months, and our aim is to make sure that your 3 months is you are not in pain, you are well functioning, you can eat well. That's the role of the palliative doctor. And if you know in 3 months, you can decide, I want to have one last fling either at the casino, $10,000 as a high roller or whatever, maybe you have 100,000 and I say, I just want to do this, pretend to be, to live out a fantasy, or they will want to visit their friends. They will even, I often say to my patients, it's a blessing. And sometimes you may have friends, old friends you want to reconnect with. Better that you tell them now than they read the obituary and they come to your funeral. Yeah. So these are very specific, and because people like you and me, without this knowledge of when we are going to die, life can be very fragile. You can go out driving and boom, one accident and we are gone, without saying goodbye to your family, without doing an LPA, without refreshing my CPF will and nomination. So life is uncertain. In a way, we need to treasure every day as we live. But it is a blessing to be able to go out in your own way, in your own rules. Yeah.
All right. Thank you, Dr. Chin, for that sharing of your personal encounter with the patient. I think you really put things into perspective for today's talk. Thank you so much. And
Thank you.
Frostbite has a follow-up question, and
Yes.
is asking about what are the essential things that we have to prepare, before deadline, right? Assuming it's before the person pass on, things like CPF nomination, your best NRIC photo, things like that.
Okay. I don't have a specific recommendation, because we deal with the symptoms, the medical conditions. But often I talk to the family, in terms of the patient without the family, to ask them about their wishes. Often a lot of us, we may have some bucket wish, bucket wish list, whether it is going back to for the elderly, a lot of them may not be originally from Singapore. They may want to go back to their own hometown or not. They would like to have one last look at where things are, and if whether they can travel, or it may be something that they want to eat, an experience they want to enjoy. So it is very individualized, but in general, there is the logistics that need to be attended to, and often we want to know their wishes, whether in Singapore it's very easy, where most of the time people are cremated, unless you're Muslim, then it's buried. But often the funeral arrangements, we would like to be as close as what the person wishes. There might be people also who would want to get baptized, at the end. Maybe they have children who are Christians and they themselves would wish to be baptized. And we have a couple of patients like that, of their own volition. They mentioned that. And so these are very personal, for their last steps of the journey when they meet their maker. So the nowadays we have moved on to, and interestingly, we have just moved on to a medical cert regime. So there's no longer any more paper cert. You will be on the health hub with electronic medical cert. Yeah, because we like to say that even everything on the cloud lives forever, including your death cert. Yeah.
Right. Thank you, Dr. Chin, for answering that, and for Frostbite as well for your two-part question. I think the time is almost there, and I'd just like to conclude tonight's Q&A session. So thank you everyone for posting your question, and of course to Dr. Chin as well for sharing and for answering all the questions that we have for him from everyone here tonight. So I think it's now time for Dr. Chin to take his break and for him to leave. So good night, Dr. Chin.
Good night. Thank you. Bye-bye.
So next up, we have this, just like to do a little small closing. All right. So if you can see up on the screen right now, we have this Yum Cha session with doctors from Icon Cancer Center. And there is a topic, which is colon cancer. And it's on the 24th of June. It's on Friday. And the time is 12:30 to 1:30 p.m. All right. So do sign up for this closed group workshop by scanning the QR code. on the screen now, right? So we have also limited slot for this session, so do sign up early, right? So at this point, we would just like to appreciate it if you can complete this feedback on tonight's session. So do scan the QR code once again to give us your comment. The QR, this entire thing is also pinned right at the top of this Facebook comment, so you can find it easily right there. So now we'd like to conclude this session by announcing these winners for our Facebook contest. So here you go. So congratulations to winners Elizabeth Lee, Orange Tan, Esther Lei, William Chow, and Melvin Ng. So thank you for participating and congratulations for winning them. So we'll be contacting you on how to collect your prizes. So do keep a lookout for that. So our next Facebook Live session, right, will actually be on this topic called 实现更健康的心态. So it basically means to discover a healthier mindset, right? So it will be on the 18th of June, okay? So same place, same time, 8:30 p.m. on our Facebook platform, right? The speaker will be Zheng Kaiyun. So she's Sarah. She's actually our very own counselor from 365 Cancer Prevention Society. So do turn up and show us your support. So once again, do like and share our social media pages from both of us, right? From 365 CPS and from Icon Cancer Center. So you can have the up-to-date details on our recent happenings. So once again, thank you so much for joining us tonight for this Facebook Live session. And of course, thank you to Icon Cancer Center. So I would like to hope to see all of you in the next session. So do take care, stay safe, and good night, everyone.